name is Chiadi Ndumele. I am here today to have a discussion with my colleague and friend, Dr. Sadiya Khan, who was the chair of the scientific statement on the American Heart Association's new Prevent calculator. So the goal of this discussion is to start to address some of the various issues that individuals starting to engage with this calculator may be wondering about. So thank you so much for doing this today.
It's great to be here.
Excellent. So I thought we would just start with asking a really straightforward initial question, which is what motivated the development of this new Prevent calculator?
That's a great question. And really, some of it happened to just be being at the right place at the right time. As you know, having led the scientific statement and the initiative around cardiovascular kidney metabolic health, some of our discussions really started to revolve around the fact that we needed risk prediction equations that accounted for predictors that incorporate CKM health, kidney function measurements, metabolic status, as well as incorporated outcomes that are relevant to the population that may have CKM syndrome, particularly the inclusion of heart failure. So I think this really started to revolve around the concept that we need to be able to estimate risk accurately and precisely for people with CKM syndrome, but also the general population. The second piece of this was that we know over time that the population has changed. Risk factor levels have changed. Medication treatment have changed. We have a lot more people on statin therapies now. And so the pooled cohort equations have really been outdated over the last several years. And so there's also a need to be able to more accurately and precisely predict risk in a contemporary population.
That's really helpful. I imagine these days now we have so many new preventive therapies beyond statins that we're starting to think about how we think about risk in this modern area and guide our thought process about some of these newer approaches as well.
I think that's another piece that's really important. At the time of the release of prior risk prediction equations, we were really focused on statin therapy. And so ASCVD as an outcome made sense. We're now thinking beyond ASCVD as well as beyond statin therapies. And it's incredible the tools we have in our armamentarium to try to prevent cardiovascular disease and optimize health. And so we want to be able to identify who are the people that would greatly benefit or most benefit from some of these therapies.
Yeah. So as we're embarking on this new calculator, maybe it's helpful just to give a synopsis of the elements that are new in the Prevent calculator.
Yeah, a lot of what we thought about early on was what are the things that make sense in the pooled cohort equations or prior risk prediction equations. And so the traditional risk factors that were present then and are still relevant now, like blood pressure level, cholesterol level, diabetes status, are there. We have sex-specific equations similar to before, but we also now incorporate measures of kidney function, particularly GFR. We also have an optional equation that incorporates albuminuria with UACR, an optional equation for hemoglobin A1C, and importantly, an optional equation that for the first time incorporates a social determinant of health with zip code based, the social deprivation index.
Yeah, and you mentioned this concept of focusing beyond ASCVD and thinking about total CVD. What do we mean by total CVD?
Yeah, that's a great question. It's definitely something that we thought long and hard about. How can we define what are the endpoints that matter and what are the endpoints we can measure well as prevent? And so ASCVD makes a lot of sense when we think about atherosclerotic cardiovascular disease that includes coronary heart disease and stroke. And we also newly added heart failure as one of the endpoints so that we can come up with this risk estimate for a composite of total cardiovascular disease.
That's really helpful, particularly in this era where we're going to be thinking about CKM syndrome and the outcomes that are relevant to the population. So we've mentioned the pooled cohort equations, which of course have been an amazing part of our approach to risk-based prevention over the last decade. How does Prevent differ from the pooled cohort equation?
Yeah, that's a great question. A lot of what we did was build upon what the pooled cohort equations are already doing. The bedrock of our approach to preventive care is really risk-based prevention. And so taking the pooled cohort equations and seeing how we've used that in terms of estimating risk and guiding preventive therapies based on a person's absolute risk. Prevent uses a very similar foundation, and the idea is that if we can more accurately estimate total cardiovascular disease risk, we can have a more holistic conversation about with our patients about what the options are to help prevent or reduce that risk. Some of the things that are different that we've mentioned already include different predictors. We add kidney function. We have optional equations that incorporate metabolic status and social deprivation index. The outcomes, incorporating heart failure. And another thing that we've done it differently has been to remove race as a predictor, but ensure that the prevent equations accurately and precisely estimate risk across racial and ethnic groups, despite not having it in the model itself.
Excellent. And then there's been some interesting, there's a lot of discussion around the fact that we're now not just talking about 10-year risk, but also 30-year risk. What's the importance of thinking about that kind of longer term risk horizon, and what populations where that be where it has particular relevance?
Yeah, that's another thing we were thinking about was how do we really broaden the relevance of risk prediction, particularly for the young adult population. One of the things that we spent some time talking about in the overall development of the CKM construct was that we're seeing some of these risk factors emerge earlier in the life course. So we have this really epidemic of obesity and metabolic syndrome that is occurring even in young adults. And so being able to accurately estimate risk, even in young adults, when a 10-year time horizon may not make a lot of sense when you're 35, not having an event for the next 10 years is a good outcome. But really what we want to see is not having an event over the next 30 years. So the models incorporate age as a time scale. So it enables the estimation of risk at the 10-year horizon, which is what we're used to with the pooled cohort equations, but also for the 30-year time horizon, which is particularly relevant for young adults. We incorporated a broader age range in the derivation, so the models can be applied from age 30 to 79, and that also helps build in those estimates for that 30 to 59-year age range, where 30-year risk is highly relevant when most people may have low 10-year risk, but may still be at high 30-year risk.
That's really helpful. Now, as we're thinking about prevent and thinking about the pooled cohort equations, they're both powerful in terms of risk discrimination. Are there any notable differences otherwise with regards to performance?
One of the things that we looked at in the development of the model was how did the prevent models compare with the PCEs or pooled cohort equations? And as you mentioned, the discrimination or the rank ordering is very similar. But what we saw was the prevent models were well calibrated. So we saw a calibration slope of 1, which represents the observed to predicted risk lining up. When we looked at the pooled cohort equations, we saw that the calibration slope was about 0.5. And that means that the pooled cohort equations are overestimating risk by a factor of about 2. And a lot of that has to do with the fact that the contemporary population has a lower than predicted event rate when we use older data like the pooled cohort equations did.
Yeah, that's helpful. So, powerful tools and important differences that you've noted. How do we start to conceptualize the use of prevent in clinical practice?
I think one of the things that we hope that this tool allows clinicians and patients to do is inform discussions and decisions about risk. One of the advantages of being able to use the prevent model, as you mentioned, was this idea of being able to expand the conversation, look at 10-year risk, 30-year risk, and really think about the life course perspective. Being able to incorporate risk for heart failure, estimate the risk for heart failure itself or total cardiovascular disease. I think one of the things that we're waiting on as we have this tool now available is how will the guidelines incorporate this and what are the specific thresholds that may be important for specific therapies. We mentioned earlier that we have really a wide variety of novel therapies now available that can lower the risk for cardiovascular disease in our patients. So how do we line up which patients will benefit the most from which therapies?
So a lot of new horizons that we have to tread in terms of understanding how to use this, but sounds like promising in terms of where the future may go. So you mentioned the fact that a lot of this started with an initial focus on this concept of cardiovascular kidney metabolic health. And we know that we have the cardiovascular kidney metabolic construct includes a staging approach to thinking about different levels of syndromic severity. How do we How does this prevent risk calculation integrate with the CKM Health approach, particularly with the staging construct?
One of the great things about doing this together with the CKM syndrome staging was to be able to keep these synergistic and so that they can inform each other. As you're screening individuals for CKM syndrome components, that helps inform your calculation of the prevent estimate. Now, vice versa, one of the things that we incorporated into the stages as we think about stage 0 being in optimal health, stage 4 having prevalent disease, and in between 1, 2, and 3 being varying levels of risk, the prevent equations can really help to define or discriminate absolute risk across those stages, particularly in stage 3, where we define subclinical disease, as well as a very high risk or predicted risk for CVD with the prevent model as being a risk estimate of greater than or equal to 20%. This really helps to identify that group that sometimes has been called primary and a half prevention, that is at very high risk for developing prevalent cardiovascular disease in the near future, and allows us to intensify our prevention efforts in that group.
So prevent is integrated into the staging construct for identifying that very high risk primary prevention population, but then also provides some complementary information for those individuals in those earlier stages as well. That's really helpful. As we're thinking about the next steps with regards to the conceptualization of this prevent model, one of the things that's come up a lot is the fact that you mentioned earlier, race is no longer one of the, in the pooled cohort equation, we had race-specific algorithms, and we don't have that any further. So why don't we start off with a discussion about why there were race-specific algorithms in the pooled cohort equation to begin with?
Yeah, I think it's really helpful to try to consider why was it included before. And I think the important thing was to make sure that we are accurately and precisely estimating risk. So any risk model needs to be able to perform well in order to do its job. And in the pooled cohort equations, one of the things that came up was that if you don't account for race, which is a social construct and incorporates a wide variety of lived experiences used as a proxy for those circumstances and different experiences, including experiences of discrimination, structural racism, other barriers, then the models didn't perform well. And so you had this situation where you may be underestimating risk and thereby worsening disparities if you don't account for it in the risk estimation. Now, when we looked at prevent, we didn't have race in the model, but we did incorporate kidney function as well as have an optional model that incorporates social deprivation index, and then looked at how it performed in self-identified Black Americans, white Americans, Asian Americans, and Hispanic Americans. And we saw similar accuracy and precision across racial and ethnic groups, even without race in the model. That was the most important thing.
So that's really helpful. So at the end of the day, just so I make sure I'm paraphrasing, getting this correctly, you're saying that it was the performance and the concerns about the performance of the risk model in different racial groups that led to different equations in the pooled cohort equation. But in this, we have less of that concern because we're seeing predicted risk equaling to actually observed risk, with that calibration being around 1. Now, the group that was used in the pooled cohort equations versus the kind of the diversity and the generalizability of the group in this group. Can you speak to that a bit in terms of how that may have impacted this?
I think that's another thing that has really changed in the last decade is the ability to access contemporary data sets incorporating data from electronic medical records. We were able to use data from over 3 million individuals. And so what that set up was this very diverse, generalizable population to be able to derive the models from, that then we validated in a different set of 3 million individuals and demonstrated the calibration that we were talking about.
Excellent. So I guess the other question I would ask that has come up is, what does this not mean? So not having race in the model, does that mean that we are not thinking that there are racial disparities anymore, or that there's been some achievement of racial equity? What does not having race in the model mean from that standpoint?
Yeah, I think it's really important to make sure that we emphasize that racial disparities in cardiovascular disease have been persistent for the last 2 decades and continue to exist. And in fact, when we look at the estimates from the PREVENT model, we see that the predicted risk for Black Americans is consistently higher than that for white Americans. And that occurs as a result of a variety of different lived experiences that reflect in risk factor levels. We know that the burden of hypertension is greater among Black Americans compared with white Americans. And then that reflects in their predicted risk of cardiovascular disease. So it's really important to make sure that we are being very, very clear about the fact that there continue to be unacceptable racial disparities in cardiovascular disease and overall life expectancy in this country that we need to pay attention to and focus on. And some of that is really downstream of risk modeling or risk estimates, but in how healthcare is accessed, how healthcare is delivered, and having a holistic approach, as we talked about in the CKM statements, of how do we consider assessment and intervention of social determinants of health that can improve this.
Yeah, so it's really helpful that the point here is about estimating risk accurately in different groups. But that is a starting point. And the next piece is how we actually address those downstream disparities, so many of which are driven by these social determinants of health. And as you say, there's such a focus on that as a part of the holistic care models in the CKM Health construct. So that's really helpful. Let's talk a bit about this concept. You've mentioned add-on models. So the base models versus the add-on models. So what does that mean? And when should we be thinking about that?
Yeah, one of the things we really wanted to offer was the flexibility to be able to incorporate different predictors when they were relevant to a patient. So particularly when we think about a patient with chronic kidney disease or a patient with hypertension or diabetes that's getting screened for albuminuria, then being able to incorporate that to actually improve the precision of the risk estimate. But not everybody in the general population is going to get screening for UACR. So we didn't include that in the base model. The idea was the base model should be applicable to any US adult aged 30 to 79 that does not have cardiovascular disease, but that these add-on models, particularly the UACR or hemoglobin A1C, are relevant to specific populations for which those markers would be used for screening. Now, the third add-on model is that with social deprivation index, or SDI, which is a zip code-based determinant. Our goal there was, especially in this era of electronic medical records, where almost every clinician would be working with a patient where that zip code information would be readily available, to be able to incorporate that whenever it's available. In fact, we also incorporated a missing coefficient there, so that if somebody does not have a residence or has unstable housing, that we can also incorporate that risk related to it.
That's helpful. And it's important, I think you emphasize that it's generally going to be available, and when available, we'd love to use it, though we only have right now social deprivation index for the United States, correct?
Exactly. The zip codes are just for the United States. So the base model could be used anywhere, but the add-on model with social deprivation index is relevant to US adults.
Okay. So now I have a little bit of a technical question for you, which is some aspects of interpreting the model. So it frequently comes up, as you know, in prediction, that when somebody says, hey, I'm going to put my patient on a therapy, I added that therapy, and all of a sudden the risk looks higher, or I lowered some risk factor level and some risk goes paradoxically in the other direction. What does that mean? And is that how we should be using the calculator, or how do we interpret that?
Yeah, that's a great question. So the risk model itself is meant to be used as a starting point. So when you put in the risk factor levels, whether or not someone is on a therapy, and what their predicted risk is over the next 10 years. If you have a patient whose predicted risk is 10% over the next 10 years, that means of 100 people that are like that patient and have the same risk factor levels, 10 of them would have an event over the next 10 years. Now, once you act on and or start a new therapy or intervene for their risk factor levels, that patient is now a different person. And so modifying the model to be able to provide a new estimate doesn't work exactly that way. We know from clinical trial data what the benefit of lowering blood pressure is, starting a statin, or starting other therapies are. And that's where being able to understand how risk changes is where we want to extract that information. The model itself is really meant for that starting point to be able to calculate where someone is starting before you intervene.
So if we're thinking about it from that standpoint of a starting point, it can sometimes be the case that people who are on statins sometimes start from a place of higher risk, but just putting somebody in a statin doesn't mean that we're increasing their risk. We should go by what we know in terms of the clinical evidence. Is that what we're saying?
Exactly.
Okay, that's really helpful. Now, obviously, this has been a great advance in terms of what has happened with Prevent. Uh, where else does Prevent need to go? What are the next steps that are needed in terms of really fully codifying this and incorporating this into clinical practice and into our communities?
Yeah, I think one of the things we touched on was really being able to better capture the social determinants of health. And so while it's a starting point to incorporate the social deprivation index, that's still a place-based measure that really doesn't get at some of the lived experiences that a person may have that may influence their health. And so being able to incorporate and evaluate individual level social determinants of health and whether or not that would improve risk discrimination or your ability to estimate risk accurately is, I think, really important, and is actually the focus of 3 new grants that have been funded by the Doris Duke Foundation. In addition to that, some of the things that we've seen are just barriers in being able to understand how we can implement risk models within our health systems. So being able to incorporate this within electronic medical records and automating some of this, I think, will be very helpful from the health system side. And the third thing will be really thinking about how we communicate this with our patients. What does it mean to have a 10% risk or a 15% risk or a 20% risk? And so focusing on the science of communication and implementation science as we then think about what are the therapies that will help reduce risk and prevent cardiovascular disease.
It seems like that's a particular frontier when it comes to this concept of 30-year risk, which we're a little bit less used to incorporating into our clinical decision making. So both in terms of how we communicate that and also in terms of how we interpret those measures.
Yeah, and I think one of the other things we want to think about is what are different ways to potentially translate that risk or communicate that risk. And this concept of net benefit comes up. So for a particular individual and for a particular therapy and for a particular risk threshold, what is the benefit of a specific therapy? What are the potential harms? And how do we incorporate that? So concepts like net benefit may also be useful as we continue to evolve the science.
And you mentioned that, as you know, pooled cohort is kind of in most guidelines. There are some steps that hopefully will be taken with guidelines to help us better understand these different thresholds. Is that right?
Exactly. I think the next frontier is really better understanding what are therapy specific thresholds. We've been so used to one threshold for one therapy, and now we have a multitude of therapies that are available to us, and we have to really personalize that for each patient.
Excellent. Well, obviously, there's a lot of really exciting steps that have been taken with this Prevent calculator, and you just also, I think, hopefully clarified a lot of the important points about Prevent, and then also where we still need to go. What final points do you want to make about Prevent to everybody who's listening?
I think one of the most important things that we know about risk prediction or risk equations is that they're only helpful when they're used. So I really want to double down on the importance of implementation within our health systems, within our practices, and really being able to translate that into improving health. I think the ability to integrate this with the CKM staging and make sure that we're doing this holistically so that the risk estimation is one part of this broader concept that we can better understand where someone is on that spectrum of CKM to be able to identify what therapies can help improve their health and ensure that we optimize cardiovascular kidney metabolic health from an overall perspective.
That sounds great. Well, thank you so much for sharing so much of your insight and so much of your wisdom and regarding the new Prevent calculator. And thanks so much to everybody who's listening for spending time with us as well.
Thank you.